I'm the Director of Education and Communication for a national organization called the Migrant Clinicians Network. So on behalf of the members of the Special and Vulnerable Populations Diabetes Task Force, I want to welcome you to today's webinar. And this is the third webinar in our four-part series titled Diabetes in Special and Vulnerable Populations, a national learning series. Today's webinar is on health center strategies for diabetes prevention and screening for children, adults, and the elderly. It's a collaboration between three national cooperative agreement partners: the National Center for Equitable Care for the Elderly, the National Nurse-Led Care Consortium, and the School-Based Health Alliance. So, moving on to our learning objectives for the day, we want to explore diabetes prevention and care strategies across the lifespan. We'll be discussing standards of care in the screening and prevention for children, adults, and the elderly. We want to engage you with case examples and experiences from the field. And finally, we want to connect you with resources to outreach opportunities and tools and resources that you can apply and adapt in your own setting. To give you a little bit of background information about the different organizations who are part of today's webinar, the National Center for Equitable Care for the Elderly aims to improve the health care of older adults age 65 and above by providing training and technical assistance to community health centers and lookalikes committed to improving health care delivery for the older adult population. Their technical assistance focuses on helping organizations assess their readiness for change, training staff to build core competencies and organizational capacities in healthcare integration and care coordination for older adults. The overarching goal of the work that they do is to increase healthcare access for older adults, increase the number of health centers that provide social services, and decrease the number of elderly patients with uncontrolled type 2 diabetes. So the National Nurse-Led Care Consortium is our second partner, and they seek to advance nurse-led healthcare through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. The consortium is rooted in the nurse-managed health center movement, and they have an agreement with HRSA to provide training and technical assistance to health centers around improving health access, equity, and outcomes for patients who are residents of public housing in particular. And then the final organization today is School-Based Health Alliance, which the School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. They believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is a solution, bringing healthcare to where students already spend the majority of their time, which is in school. When health and education come together, great things happen. Attendance improves, conditions like asthma and diabetes are better managed, behavioral health issues get quick, expert attention, and we all know that healthy students make better learners. We would also like to recognize the other national cooperative agreements who are participating in the Special and Vulnerable Populations Diabetes Task Force. This is a list of them here. I won't read through all of them. Hopefully many of you have participated in the two previous webinars we had, which were developed by some of the other organizations on this list, and we'll have a fourth and final webinar for this project year coming up, and you'll find out more information about that. Just a little bit of information about diabetes, HRSA-funded diabetes activities in particular. And for those of you who have participated in the past, you have heard some of this already. But just so you know, HRSA is placing particular emphasis on these in the next 3 years of some of the work that they have funded on diabetes in particular, really trying to move the needle on improvement of diabetes care for vulnerable populations and health center groups. They have funded the work of this task force, of which, you know, the members of which you saw on the previous slide. There is a lot of work going on sponsored by NAC, looking at a clinical change package for diabetes care. There are a number of small national cooperative agreement diabetes learning collaboratives you can be a part of, and then there's the diabetes quality improvement peer learning teams, which are doing a lot to bring health centers, PCAs, HCCNs, and national cooperative agreements together to discuss strategies for improving diabetes care. So before we dive into content, I want to review a couple of housekeeping items. We're looking here at an example of the GoToWebinar attendee interface, which is made up of two parts: the viewer window, where you're seeing my slides, and the control panel, which for most of you is probably off on the right-hand side of your screen. The viewer window allows you to see everything that we share on the screen, and the control panels allows you to control your experience with this platform. So if you click on the orange arrow button, you can hide or show your control panel. So if it's blocking some of the content, you can hide it if you don't need to. And then you can see there's places there where you can chat and ask questions. We will be addressing questions and comments at the end of the webinar. You can enter your questions or comments into the question field here. Obviously, we don't have audio enabled for you, but we do really encourage you to be participatory through the use of the questions and comments. In case of technical difficulties, yours or ours, you can relax. We're recording the webinar, and we will make the recorded session available along with the presentation and any resources mentioned. And before I introduce our speakers, I also want to let you know that the webinar is accredited for continuing medical education as well as continuing nursing accreditation. And in order to receive credits, you must fill out the post-webinar survey evaluation at the end. And there's a question there which asks you whether or not you would like to receive credits. Then you can also indicate there whether you prefer to receive an electronic or hard copy of your certificate. Okay, wanted to introduce our speakers. It looks like we had a little bit of trouble getting everyone on, but it looks like everybody's on now, which is fantastic. So I'm going to go ahead and go through all four of our speakers here and introduce all of them to you now, and then I don't have to interrupt as everyone is speaking. So our first speaker is Tanisha Daly. She grew up in Miami, Florida, and studied food science and human nutrition at the University of Florida. She attended medical school at the University of Chicago and completed her residency training at the University of Chicago Comer Children's Hospital. Dr. Daly completed her fellowship training in pediatric endocrinology at the Children's Healthcare of Atlanta, Emory University School of Medicine. After completing her pediatric endocrinology fellowship training, she continued on at Emory University as faculty. In her clinical role, she works at Children's Healthcare of Atlanta as a pediatric endocrinologist. Dr. Daly specializes in transitional care for patients with type 1 diabetes and cystic fibrosis related to diabetes. Our second speaker is Andrea Vittori. She is the Primary Care Director for Public Health Care Management Corporation Health Network and Clinical Director of Mary Howard Health Center for the Homeless in Philadelphia, Pennsylvania. Andrea has over 25 years of experience working as both a nurse practitioner and a registered nurse with safety net populations in general and the homeless in particular. Our third speaker is Elena Toski. Dr. Toski works as an adult endocrinologist in the adult clinic, mostly focusing on type 1 diabetes and the adoption of technology to improve diabetes management. She's the director of the Joslin Diabetes Technology Program. Her research focuses on the use of technology in a clinical setting to improve diabetes outcomes. In clinic, she sees patients with type 1 diabetes in different stages of their lives and their disease and helps them to work on glucose control and manage complications. She's an expert in the use of new technology such as insulin pumps, continuous glucose monitoring, insulin pen caps, and a web-based nutrition application. She is responsible for the Joslin Diabetes Technology Program. She's also been involved in multi-center clinical trials evaluating the effectiveness of continuous glucose monitoring in type 1 and type 2 diabetes on multiple daily injections. The safety of bolus insulin based on continuous glucose monitoring data with or without self-monitoring blood glucose, and the development of a mobile app to help manage patients. She's an investigator on the only online registry for type 1 diabetes in the United States, as well as an industry-sponsored trials examining the effectiveness of new insulin in continuous subcutaneous insulin infusion. And finally, our last speaker is Gina Trignani, who is a registered dietitian She is the Director for Training and Capacity Building at Health Promotion Council. Her expertise is in the provision of technical assistance and capacity building to local and statewide organizations to improve access to and utilization of evidence-based chronic disease and diabetes self-management and prevention programs. She currently directs the Health Promotion Council's Administration for Community Living funded Pennsylvania Community Living Initiative, it's a long name, to scale and sustain the Self-Management Resource Center's Steps to Healthier Living Diabetes Self-Management Program, as well as the Pennsylvania Community Clinical Integration Initiative, funded by the Pennsylvania Department of Health, which aims to increase access to certified diabetes self-management education programs and Centers for Disease Control and Prevention recognized diabetes prevention programs. So with that, I would like to turn things over to Dr. Daly. And Dr. Daly, if you're there, I will stop sharing my screen and you can share yours.
Okay, sounds great. Can everyone see my screen?
Yep, I can see it.
Oh, wonderful. Hi, so my name is Tanisha Daly. I'm coming to you guys from Atlanta, Georgia. And my talk today is going to be discussing the emerging epidemic that we're seeing as endocrinologists of type 2 diabetes in the pediatric population. And really the focus of my talk is going to be the prevention of type 2 diabetes in this population. I have no financial disclosures. And the objectives of my lecture today are going to be to understand the increasing incidence and prevalence of obesity. We'll discuss why that's important. We'll understand the increasing incidence and prevalence of type 2 diabetes in our pediatric population. And we want to identify who to screen for type 2 diabetes. And we want to see how we can prevent this condition from ever occurring in our population, which is the pediatric population. So I think this slide actually is a really cool slide. I remember I've been seeing this for several years now. First when I was in public health school, and then I've seen it as being a physician. And I think what it highlights is with a 20-year time span, how the change in obesity amongst adults occurred in our country, which in 1990 was less than 10 to 14% of the adult population, to 2010, where we're seeing obesity in the adult population between 25 to greater than 30%. And so the next few slides, I'm going to just take us from 2010 to 2016, and you're going to see this map of the United States kind of change. The key at the bottom is going to be a little different, and so I'm going to hold at the 2011 map for just a second to just orient you. You can see that the green states are going to have obesity rates that are going to be 20 to 25%, whereas the orange states are going to be 30 to 35%. Yellow states are 20 to 25 to 30%. And over the next couple of years, what you'll see is the color of this map change to where we are mostly seeing obesity rates that are greater than 30%. So just bear with me as we go through. And so we pause here at 2016. And in 2016, I think what's actually really interesting is you see the western half of our country has obesity rates at 20 to 30%. And the Midwest to eastern part of our country, not including the Northeast, have obesity rates that are relatively greater than 30%. And we have a few outliers in the South. So my poll question today is, which 5 states have a prevalence rate of obesity that's greater than 35%? Ooh, I'm sorry. Are you guys able to do the poll? Okay. Okay. So in summary, what I wanted to say is no state had a prevalence of obesity less than 20%, which is drastically different from 1990, which was only 26 years earlier from 2016. 3 states in the District of Columbia had obesity rates between 20 to 25%. 22 states and Guam had prevalence of obesity between 25 to 30%. Puerto Rico, the Virgin Islands, and 20 additional states had obesity rates between 30 to 35% or greater. 30 to 30%. And the answer to my poll question is the 35% or greater, which are only 5 states, and that's Alabama, Arkansas, Louisiana, Mississippi, and West Virginia. So when we talk about obesity in children, we use a child's weight, and that's used in an age and sex-specific percentile for BMI, rather than the BMI categories that we typically use for adults. And this is really because children's body composition varies as they age, and it also varies between girls and boys. So when we talk about obesity in teens and children, we say that someone is overweight if they have a BMI percentile that is between the 85th to the 95th percentile, and they are obese if they have a BMI percentile that is greater than the 95th percentile. So the next slide, we're actually going to transition. The data is coming from CDC, and it looks at prevalence of obesity among youth between 2 to 19 years of age. We can look and see that this graph on the left, these bars on the left represent all of the pediatric population between 2 to 19 years of age, and then we break it down to different sex categories. And we can see that what's notable is as we are in our adolescence and young adulthood, that the prevalence of obesity is higher amongst this group. When we look at obesity prevalence amongst the same population, but break it down by sex and race and Hispanic origin, we see that the prevalence of obesity is actually highest amongst Hispanic in all categories, followed next by non-Hispanic Black. And then when we compare obesity trends from 1999 to 2014 with adults to the pediatric population, you can see as the adults increase, the youth have as well. Question if there is somewhat of a flattening between 2009 and to 2012. So why is obesity important from a dollars and cents perspective? And the thought is that we'll have about 1.4 billion additional healthcare dollars for outpatient visits and health expenditures just because of childhood obesity. And the Brookings Institute has looked at this and said, if all 12.7 million US children and adults with obesity became obese adults, the individual cost would be greater than $92,000, and the societal cost may be more than $1.1 trillion. So these are like significant dollar and cents impact of obesity on our population. Unfortunately, obesity does impact lower income families more, and we can see when we look at WIC data, about 14.5 of the WIC participants aged 2 to 4 years of age were obese. And what's actually also interesting is the difference that we can see from different WIC agencies. For example, Utah, their obesity prevalence was about 8.2%, Virginia about 20%. And when we look at the WIC data, we see that American Indian Alaskan natives actually have the highest obesity rates, followed by Hispanics, and Asian Pacific Islanders have the lowest. So this is the link that I was trying to, why I spent so much time discussing obesity. And type 2 diabetes is exponentially increased if someone is obese as a child. 85% of the children who have type 2 diabetes are either overweight or obese. And we also see that the rates of prediabetes are increasing in the pediatric population. Prediabetes is really important for us to catch prediabetes because that is an opportunity that we can restore someone to normal glucose tolerance. I also want to just talk about search, and I think the reason why search is important is our largest national multi-center database that we have that was launched in 2000. And the goal is really for us to understand diabetes, type 1 and type 2, amongst children and young adults. There are 5 search centers across the country: South Carolina, Ohio, Colorado, California, and Washington. And the goal is to answer questions about diabetes, its complications, and how children and young adults are living with diabetes. And it's through the search data that we see something that's a little different. And we look and we can see that from 2003 to 2012, that the average amount of diabetes that's being diagnosed per year. And we can see what the other slides about obesity indicated, that the number of patients being diagnosed with type 2 diabetes is increasing. What's actually a little different than the CDC data is who's impacted. And if you can recall from the CDC data, there were Hispanic, people of Hispanic descent seem to have the largest prevalence of obesity, whereas the search data states that type 2 diabetes, which is this graph here on the right, is highest amongst Native Americans and non-Hispanic Blacks. Just like obesity, type 2 diabetes is most likely to occur in folks who are from lower socioeconomic backgrounds. And ethnic minorities and low-income children are more likely than their white middle-class counterparts to have type 2 diabetes. And this is not something that's just a United States problem. We're seeing this problem worldwide. And Europe is also seeing an increased prevalence of type 2 diabetes in their pediatric population. We know that type 2 diabetes is multifactorial. There is a genetic predisposition. So if you have a family history of type 2 diabetes, the likelihood of you having type 2 diabetes does go up. We also know, however, that it's not just a genetic susceptibility. There are environmental factors such as someone's obesity or decreased activity or nutrition, what we put in our body, and birth weight. And there are certain medications that can impact the islet cell function and cause type 2 diabetes. So this next slide really just kind of looks at the pathogenesis of diabetes. I'm going to ignore the left-hand side of the slide because that's really talking about type 1 diabetes, and kind of focus on this right-hand side of the slide, looking at the impact of genes and the environment, leading to a state of inflammation and metabolic stress that then causes beta cell dysfunction. And remember, beta cells are where insulin is produced. And if we have beta cell dysfunction, we end up having higher blood sugars or hyperglycemia. And long term, we're talking about complications that not only affect small vessels, but the large vessels. So small vessels or microvascular complications would include retinopathy or damage to the eyes, neuropathy, damage to the nerves, or nephropathy, which is damage to the kidneys. Our macrovascular complications or big vessel complications can include coronary artery disease, peripheral artery disease, which can then relate into layman's terms of a stroke. So my next poll question is, a mother's history of gestational diabetes does not increase the fetus's risk for developing type 2 diabetes as a child, and this is true, false. Okay. I am going to transition back to my talk and just look at screening guidelines and who to screen. So we screen children if they are overweight. So as we said before, a BMI percentile that is greater than the 85th percentile. So overweight or obese. But being overweight or obese is not sufficient to then just screen. We want to have two additional risk factors. So a family history in a first or second degree relative of type 2 diabetes, an at-risk ethnicity, so Native American, African American, Latino, signs of insulin resistance, or conditions that may be associated with insulin resistance. So a sign that I might see as a clinician on exam might be acanthosis nigricans, conditions if there's hypertension, dyslipidemia, or polycystic ovarian syndrome. That is also concerning for and signs of insulin resistance. And the answer to my poll question, a maternal history of diabetes, or if mom has gestational diabetes, during that child's gestation, that child is at risk for developing type 2 diabetes. So when do we screen? We start screening at age 10. However, if puberty occurs before age 10, then we actually would start screening earlier than age 10. Screen about once every 3 years. But if that initial screen is abnormal, but follow-up is normal, then we would want to repeat screening annually. How do we screen? We can use fasting plasma glucose. I do caution that that may miss some children with making a diagnosis of diabetes, a hemoglobin A1C, and some people actually will screen using an oral glucose tolerance test. We often refrain from using an insulin level to screen because insulin levels really are not useful for making a diagnosis or suggesting diabetes. Diagnostic criteria. So if fasting plasma glucose is greater than 126 or a 2-hour is greater than 200, either of those, particularly in the setting of an oral glucose tolerance test, are diagnostic for diabetes. If the A1C is greater than 6.5%, that is also suggests diabetes, or a random blood sugar of 200. That's also suggestive of diabetes. And with the random blood sugar of 200, we like for them to also have some symptoms of peeing excessively, drinking excessively. So pre-diabetes, because we did discuss in the previous slide that if we can catch someone with pre-diabetes, that there is a possibility of reversing those glucose abnormalities. So when we talk about pre-diabetes, looking at a fasting blood sugar, a blood sugar between 100 to 125 is suggested of impaired fasting, and a blood sugar between 140 to 199 is suggestive of impaired glucose tolerance. So what do? We screen and we see that they have type 2 diabetes. Of course, we treat. But if we see that we have someone who's at risk, they may fit a couple of the diagnostic, a couple of the criteria that we use to screen. However, everything comes back abnormal. The focus is really to kind of address the things that make this child at risk, particularly if they are overweight or obese. So AAP, or the American Academy of Pediatrics, and the U.S. Department of Agriculture said decreased consumption of fast foods, decreased consumption of added sugar, and elimination of sugar-sweetened beverages, decreased consumption of high fructose corn syrup, decrease high fat and high sodium or processed foods, consume whole fruits rather than fruit juices, portion control and education on portion control, reduce saturated dietary fat intake, and try to do more dietary fiber, fruits, and vegetables. Try to do timely, regular meals and not encourage grazing throughout the day, especially after school. And recognize when a child or adolescent is eating out of boredom, loneliness, or particular stressors. Encourage single portion packaging and improve food labeling for easier use by customers. And this is more from a manufacturer marketing standpoint. Again, we also say if we see someone who's overweight or obese, give them a prescription. I often in my practice say give them a fit prescription. And we prescribe and support the reduction of inactivity by setting a goal of moderate physical activity, at minimum 20 minutes, goal between 30 to 60 minutes. And this is in the context of a well-balanced calorie control diet. Encourage and support patients to limit non-academic screen time to no more than 1 to 2 hours per day. Decrease sedentary behaviors and decrease digital activities. And this, is, I think, is a very key recommendation from the Endocrine Society, which they have seen improvement in childhood obesity through school-based programs and community engagement. And there's moderate evidence to suggest that community-based programs and school-based programs can have a positive impact on preventing diabetes. I'm going to quickly just refer to the 2 studies, one by Gray, which looked at type 2 diabetes in children, and they did a randomized school-based trial to allow for kids to participate in multifaceted school-based education that included coping, skills training, and health coaching to reduce the risk for type 2 diabetes. It was a 1-year study. Students in both groups showed improvements in their metabolic risk profiles. They received coping skills, health coaching, and there was a reduction in cholesterol, triglycerides, and 2-hour OGTT. BMI, unfortunately, was not improved. The second study was a national multi-center study that had over 4,000 participants and looking at the middle school population. And the intervention was environmental changes in the school setting, changes to school breakfast and lunch menus, increasing physical activity, and they really tried to reinforce their messaging through social marketing. Just like the other slide, not really much of an impact on the overweight and obesity, but they did see the reduction of BMI and waist size. So in summary, obesity in the pediatric population, what is key is looking and making sure you identify who's at risk. Remember your risk factors, and insulin levels are not useful to screen. And school-based programs and community-based programs can be important for fighting this obesity epidemic. Those are my resources. Thank you, everyone. And I'm going to move to Andrea Vittori for the next part of our presentation.
Are you there, Andrea? I had you muted, but I unmuted you, so. Are you online? Are you there?
Can you hear me?
Yes.
I am here.
Perfect.
Great. Okay. Wonderful. Okay. All right. And can you see my screen?
Not yet.
Not sure if I need to do anything else on my end. I'm seeing it.
There we go. Okay. Now it's showing, and now it's showing. Great.
Oh, there we go. Okay.
Yep. You should be
How's
good
that?
to go. Perfect.
Okay, thank you.
You're welcome.
Well, good morning or afternoon, depending on where you're calling in from. Again, my name is Andrea Vittori, and I'm a nurse practitioner, family nurse practitioner at the Mary Howard Health Center in Philadelphia, Pennsylvania. So my presentation today is focusing on adults and the prevention and screening of diabetes in the adult population. Some of this is going to be a repeat of Dr. Daly's, but I think that repetition is not necessarily a bad thing. So I think first, to understand really the importance, we really need to appreciate where we currently stand. In this country, we have over 30 million people who are living with diabetes, and that number really is expected to rise significantly with over 84 million people over the age of 18 suffering from pre-diabetes. And just to put that in some kind of perspective, that represents nearly half of all Americans who either have diabetes or pre-diabetes. That number is pretty astonishing. The ADA estimates that an American will be diagnosed, will progress to diabetes every 21 seconds. So again, I think this conversation in terms of prevention of diabetes is pretty timely given those numbers. And globally, the impact is expected to reach 470 million by the year 2030, with the largest increase expected to be seen in the Western Pacific region of the world. We know that the burden of disease associated with diabetes is significant. Diabetics are more likely to suffer from kidney disease leading to renal failure, amputation, and blindness related to microvascular compromise. And the cardiovascular complications are even more impactful, with diabetics being 2 times more likely to die from heart disease and 2 times more likely to suffer from stroke. And Dr. Daly referenced this a little bit, but I do think it's also important to consider the cost, the economic burden associated with diabetes. In 2012, it was estimated that the total economic cost of diabetes was $245 billion. That represents a 41% increase from the numbers that we looked at in 2007, when the cost totaled about $174 billion. And I think it's also important to understand that those costs represent both the direct medical costs and also the costs associated with decreased work, decreased productivity. Again, Dr. Daly touched on this, but we know that diabetes disproportionately minority communities, with Asian Americans, African Americans, and Hispanics having higher rates of diabetes compared to Caucasian Americans. So if you're African American in the United States, you have a 77% higher likelihood of developing diabetes compared to your Caucasian neighbor. Hispanic Americans have a 66% higher chance of developing diabetes. Those numbers are not only significant, but they're really important when we consider prevention techniques that we employ related to the various ethnic groups. Contributing to the burden of diabetes are the number of people that are unaware that they even have diabetes. Of the over 30 million people with diabetes, 7.2 million are undiagnosed, and a higher proportion still are unaware that they are even at risk. I mention that because it is significant that we screen these folks appropriately so people know what their risks are, and they certainly know if they have diabetes. Given what we know of diabetes and the burden of the disease physically, economically, and socially, it's incumbent upon us as healthcare providers that we do screen appropriately and we don't miss opportunities to screen. These are 2 of the screening guidelines that are published. There are others in my practice, and I know in a lot of practices we tend to use the ADA guidelines. And we look at two major guidelines, or 2 major categories. Age category, so anyone over the age of 45 is considered at risk for developing diabetes. So anyone over the age of 45 in our practice is going to get screened for diabetes. If you are under the age of 45, but your BMI is over 25, you have 1 or more risk factors, you also are going to be screened for diabetes. Normal screenings, if you have a normal test, you're going to get repeated every 3 years, every year if you have those significant risk factors. Dr. Daly spoke on or touched on some of these risk factors. For the adults, some of them are similar to the pediatric population, but we just mentioned that age is a risk factor. So again, over the age of 45. Dr. Daly spoke of weight. So anyone with a BMI over 25 is at increased risk of developing diabetes. Cardiovascular disease or a family history of type 2 diabetes or cardiovascular disease is a risk factor as well as exposed long-term steroid use. HDL less than 35 or your triglycerides higher than 250. Dr. Daly spoke of gestational diabetes. That is a risk factor, and you should be screened if you had gestational diabetes, but also if you had a baby that was born over 9 pounds. If you're hypertensive or are on hypertensive medications, obviously pre-diabetics are at risk, and then the ethnic groups that we mentioned earlier. It's easy to miss opportunities. I think it's really important that we, first of all, just recognize that the safety net population that many of us work with often have very hectic and very chaotic lives. And unfortunately, they bring that chaos very often into the health center with them. And I think it's important to recognize that. As a clinician, it's very easy to miss standard screenings when we're struggling to address all of the presenting priorities that patients bring with them when they come into the health center. That being said, it's important for us then to use the resources that we have to our advantage. And I think technology obviously is the primary resource that we have for exposure. Reminder systems within the EMR are critical. You have your IT team put in the parameters for screening and have those pop up when you open up a patient to say that this patient is due for a screening for diabetes is really, really helpful. Standing orders so that your medical assistant staff can automatically screen those patients identified by your EMR as being at risk. I'm convinced as a clinician that we really underutilize our medical assistant staff. And if we give them clear guidelines and parameters, my experience with medical assistants is that they're often much better at capturing this data and capturing those patients than sometimes even the providers are. Running reports, have a process in place where you run periodic reports using those risk criteria and then identify those patients who have not been screened and reach out to them to see if we can get them into the health center. So we're all aware of the screening tests that and where the clinical cutoffs are for diabetes, but we also need to understand where the diagnostic criteria are for pre-diabetes as well. And as Dr. Daly said earlier, we can certainly test using any one of those three testing mechanisms, so the fasting plasma glucose, the glucose tolerance test, and certainly the A1C. In my practice, I tend to use the A1C, and most of the clinicians in our practice tend to use the A1C more frequently. I find that patients more and more are understanding what that term means, or at least are familiar with it and associated with diabetes. So I think language is important. When you have a patient who falls into that risk category now for pre-diabetes, you'll often have people who will refer to that in the chart as impaired glucose or impaired fasting glucose, impaired glucose tolerance. And those terms are clinically accurate. They don't always, however, convey to the patient what you need them to understand, which is that they are at increased risk of developing diabetes. And so, for my diagnoses, I will put increased risk of diabetes or pre-diabetic. I think language is really important. And I think if patients take seriously this stage of pre-diabetes, we can get them to make the changes that they need to prevent the progression to diabetes. So what does the research tell us about diabetes prevention? The diabetes prevention program was an NIH-sponsored study back in 2002 that looked at the ability to prevent diabetes in individuals who were diagnosed with pre-diabetes. The purpose of the study was to determine intensive lifestyle changes could stunt or prevention of diabetes in those who are diagnosed with pre-diabetes. So there were there were 3 groups, in addition to the control group. Patients were put in a group who received intensive lifestyle modification, and that included dietary changes and increases. The third group who was treated with mind, the DPP showed us that even a modest decrease in weight, and by modest, they defined that as a 7% decrease in weight by limiting their overall calories and fat, and by exercising 150 minutes a week, could decrease the risk of progressing to diabetes by 58%. That is even more significant when you look at the age category. So over 60, that decrease in progression to diabetes increases to 70%. Astonishing numbers. And you know, by comparison, those treated with metformin decreased their risk, but decreased it significantly less, by 31%. And interestingly enough, when you looked at that third group by age, those who were treated with metformin over the age of 45 had a lesser effect of decreasing to diabetes. So I think one of the things, just to go back for a second, one of the things I think that really stresses is the importance, obviously, that Dr. Daly mentioned earlier, the relationship between obesity and diabetes. So what were some of the lessons that we learned from the diabetes prevention program? Diabetes, really with any kind of chronic care management, but diabetes in particular, the goals need to really be patient-centered. We know from research and we know from our experience that patients who choose their own goals are more likely to want to achieve them and are more likely to actually achieve them. I'm not sure that we emphasize this piece enough. Relationships matter. It matters that you know your patients. And it matters that your patients trust that you genuinely care about them and that you understand the challenges associated with achieving their healthcare goals. And that you are able to modify your education to take into consideration those challenges. And I'll give you an example of this. I work with the homeless population, many of whom are in shelter, and many of whom, because they're in shelter, eat shelter meals, which obviously and all too often are loaded with carbohydrates. They have little control over the meals that they eat for the most part. And so I'm not going to go tell a diabetic who's living in shelter not to eat pasta. It's just not realistic for them. And so it's really important to really know your patients and to understand some of the barriers that they have. And all of the changes that you want them to make, or they may improve for them and then have a setback. Be okay with that. If you convey to your patient that you're not okay with that, they're going to be frustrated with themselves, they're going to think poorly of themselves, and they're going to be less likely to achieve their goals. I think it's really important to help your patient identify a variety of goals that they can choose from. There are going to be a number of goals that they're going to want to achieve. If they try to take them on all at one time, they're not going to be successful. So help them come up with a variety of goals, and then help them break down some of those longer term goals into short term goals. So for example, if you find that their consumption of soda beverages, for instance, if they're consuming 3 sodas a day, they may say to you, okay, I'm not going to drink soda anymore. Well, the reality that they're going to walk out the door and stop drinking soda immediately is not very realistic. So to say to them, okay, you don't want to drink soda, so let's set that as a long-term goal, and maybe in 2 months from now, you will have achieved that goal. What can we do between now and 2 months? So maybe for this first week or two, instead of drinking 3 sodas a day, maybe now you can drink 1 soda a day or 2 sodas a day, and then just slowly back off of that. Once they've, I always tell my patients, once you achieve those short-term goals and you can now live with that, then check that off your list and move to the next goal. But I think I think this really helps kind of put patients back into the driver's seat and help them to have control over those changes. Lots of tips out there. Obviously, you know, we're not going to be able to go through all of them, and you probably have others. I want to just go over a few that, from my experience, have really helped with patients. One of the things I mentioned earlier, that language matters and language is important. I think we need to get away from the terminology of diet. I think patients need to know that this is not a diet. Diet implies something we begin and something we end, instead of looking at this is a lifestyle change that I need to implement and I need to live with for the rest of my life. And so that also ties into those short-term goals, doing them incrementally, and then being able to achieve a long-term goal down the road. That just sort of reinforces that this is a lifestyle change. So I think that's really important. Knowledge is power. Patients don't always understand how to eat healthy. And I find that sometimes all you have to do is give them the information and they'll go from there. I had a patient once who was, we could not figure out why her A1C or why her fasting sugars were so high. And it turned out she was doing pretty much everything right. She was drinking Gatorade. She had no idea because Gatorade's packaged as this sort of power drink and it's packaged as being healthy. And that was her perception, that this was a healthy beverage. And so therefore it should be okay to drink. Once she realized that, she was able to change those behaviors. I would teach your patients, you know, to be patient, not to watch television while eating. Again, this goes back to the weight loss. We know that patients tend to, and everyone tends to eat more and consume more calories while distracted. So while watching television, for instance. Planning ahead, really important. Try to teach the patients to think about what they want to eat ahead of time. Think about some of the healthy snacks that they want to consume, and plan for the week ahead. You know, if you don't plan, you tend to just grab something quickly, and we all know that. Food that we eat. The plate size in 1985 versus size in 2005 really causes an increase in consumption by 20%. And so if patients understand that back in 1985 we ate less because our plates were smaller, well then maybe get a smaller plate and use it's a lot of it use that difference. They're subtle sometimes, but they do make a difference. Excuse me. Another thing that I think a lot of our patients don't understand is the difference between the amount of calories. So for patients to understand, if you eat more in home, you're going to just your consumption, your fat and your cholesterol will be less as well. Again, don't underestimate the power of psychology. Advertisers, I like to say, have been using this for years to thinking that we're hungrier are, and that we need more calories than we do. For instance, you know, patients
Andrea, you're starting to break up quite a bit. Can you hear me, Andrea? You're starting to break up quite a bit. I'm not sure that there's anything you can do about it, but.
Oh.
We were having some breakout earlier, but now it's getting hard to hear you. I don't know what to do. Well, just continue on, and we'll, like, it comes and goes. So hopefully it's gone.
For that, I'm not sure. I'm not sure how I can fix that.
Yeah, let's just continue on.
Supersizing has, you know, way that we understanding that some cases. And I think you hold of these, if it's just on a handout and show patients, I think this is really powerful, just to see the difference between the average food that we consume, you know, say back in 1960s, and I paid.
Andrea, I'm sorry. At this point, we really can't hear. Let's see if other people are having the same issue. I think right now we're going to have to move on to Elena, just because we really can't hear what you're saying, and I'm so sorry, because we really want to. I'm sorry, Andrea. We're going to move on to Elena. Nicole, can you shift the screens?
Okay.
Okay, so Dr. Toski, are you there?
Can you see my slides?
Yes, we can see your slides.
Okay, perfect. Good morning and good afternoon, everybody. I'll try to be mindful of the time, and I will go over the elderly population. I have no financial disclosure, and I will cover in these 15 minutes a little bit briefly about screening and prevention of diabetes in the elderly. And I'll try to cover also insight in healthcare center experiencing emergent diabetes in this population, as well as successful strategies that you could use in your health centers. So as my previous colleague has already mentioned, prevalence epidemiology is rising also in the elderly population. About 30% of subjects above 65 United States have diabetes, and about 30% have diabetes not yet diagnosed. The presence of diabetes in this population increases the risk of premature death, functional disability, and coexisting illness. Moreover, they have a higher risk of several common geriatric syndromes like polypharmacy, cognitive impairment, urinary incontinence, falls, and persistent pain. The American Diabetes Association recommendation for screening and prevention are similar to the one that were already overviewed by both Andrea and And so I won't go over those. I want, however, pointed out that in this population above 65, there is an heterogeneous population. Many of them have already long-standing diabetes with possible significant complication. Others are newly diagnosed, but many they may have years of undiagnosed diabetes, which the diabetes is going to present also with a possible already complication. And some are truly recent onset of the diabetes with few or no complication. Moreover, this population has cognitive function that can be vary widely. Most of us think for elderly population, subject like this lady, frail with some cognitive dysfunction, but many of them are also very healthy, both physically and cognitively. However, one thing that we have to really keep in mind, also the lady on the right of the slide, that she looks quite healthy. If an acute sudden disease comes on, the ability of recovery is much lower compared as an adult subject. So when we talk about this population, we have also to think how they are in their life situation. Many of them may be independent, have an independent living. However, these patients have to be carefully monitored when we see them in our clinics. Many may be already on complex regimen with polypharmacy, and this can be dangerous if at any time the cognitive function of the patient changes. There might be acute deterioration. Also, acute illnesses can cause an acute cognitive or physical decline. And so close monitor as well, frequent education, re-education are very important. Many of these subjects then tend to move to assisted care. Assisted care can involve also some control on their meals. And so, as we know, diabetes and food intake are kind of related. So if they don't have control on their food intake as timing, as content, these can interfere with the diabetes management, increasing the risk of both hypo and hyperglycemia. Moreover, in assisted care, subjects may have assistance with medication. However, very unlikely to have assistance with the finger stick monitoring, as well insulin administration, and this can create some challenges. And again, subjects in assisted care, they have a higher risk of failure after an acute illness. The last situation that we can find subject in the elderly population is nursing home. Here, even more so, the ability to control their food content and timing is decreased. There is a very high possibility of side effect of oral and injectable medication. Any acute illness, anorexia, dementia, delirium can interfere with the diabetes. And most of the care is daily living, meals, as well as medication are performed by the nurse home staff. And I want to point it out that many of the nurse home staff may have a high turnover and may actually increase the risk of possible complication or reduced monitoring. So when we think of diabetes in the aging population, we have on one side the aging, the other side the diabetes. However, there are several complications and several comorbidities that can play a role in this group. Macro and macrovascular complication, as previously discussed also for the adult population. However, cognitive dysfunction, and I will discuss a little more in the next slide, can interfere with the management. Depression, that can happen at any time, and this population is a higher risk of depression. Physical disability, polypharmacy, and also other geriatric syndrome, particularly they are more prone of urinary tract infection that can trigger also delirium, have higher risk of falls, and higher risk of persistent pain that can actually have an impact on their mood and triggering depression, the impact on their food intake, triggering anorexia, among other problems. So cognitive function is very important for all of us. And in this population, we start to see cognitive dysfunction that can be from very subtle to a clear open dementia and memory loss. We have to keep in mind that in this population, Alzheimer's type and multi-infarct dementia are twice more often than in age group match population. And what happens is that when there is an executive dysfunction, subject may have a hard time to perform complex tasks. For example, monitor finger stick, administering and insulin, as well as deciding the right dose of insulin to take, follow a sliding scale, for example. And also, they may have a hard time in the timing and the control of the content of food. So all these, again, can impact on the diabetes management, particularly hypo and hyperglycemia. So when we think of diabetes management, we think about hyperglycemia, we think about risk factor, as was we have talked about in adult patients. But moreover, we have to think about the barriers that in this population may be even higher than in adults. So evaluating clinical, functional, and psychosocial barriers are very important. And as Andrea was pointed out, partnership between the physician and the patient and caregiver is a must in this situation, to try to find the best way of managing the diabetes, reducing possible acute complications that are even more deleterious than in the adult cohort. So actually, the American Diabetes Association has created a framework depending on the life expectancy of a subject in this cohort, depending on if they're healthy and they have a long life expectancy, then we should treat them as adult patients, an A1C goal less than 7.5%, blood pressure and lipids as we manage adults. Keeping in mind that those patients, however, they need to be monitored more closely and screening for possible new cognitive dysfunction and functional status may occur at any time. Subjects that have a complex intermediate life expectancy, then the A1C can be a little less aggressive with less than 8% as a goal. And then when patients have a very complex, poor life expectancy, for example, long-term residence in a nursing home, subjects that have end-stage chronic illnesses, or subjects that have moderate to severe cognitive impairment should be have a less aggressive A1C or less than 8.5%, as well as the blood pressure control should be less aggressive as well. So how can we, in our clinic, achieve these settings and try to revisit our treatment to achieve these settings? We check A1C, and A1C is less than 7. Clearly, we should look, is the patient having multiple comorbidities? Are the medications that cause that is on are causing hypoglycemia. If the patient is reaching A1C less than 7, is just on lifestyle modification or metformin, in this case, we can just leave the treatment as it is. However, if there are more aggressive therapy, and in particular medication that can trigger hypoglycemia, then we should liberalize the goal and change the strategy. If the A1C is between 7 and 8%, then again, we should look at the medication they're on to achieve such a goal. And again, if medication can trigger hypoglycemia, then we should revisit our treatment. While if there are medications that are unlikely to cause hypoglycemia, we can say that the patient has a goal. And then if A1C is more than 8%, however, a patient has multiple comorbidities, there are limited life expectancy and difficult of coping, then maybe patient is already a goal, as long as we are able to avoid acute episode of hyperglycemia. Why if the patient is more, has a longer life expectancy, we might try to aim for less than 8%. So treatment for reaching the glucose control is the same for adults. Metformin is the first line, is very well tolerated, is low cost. If GFR is above 45, can be used in patient if is deteriorating and is between, but still above 30, can be still used. As a side effect, there might be some GI intolerance as well as weight loss, which in this population may not be as welcome as in younger populations, since patient may be already frail. If a dual therapy is needed, we always should keep in mind the efficacy of the treatment that we're going to pick, how much risk for hypoglycemia the treatment has, what's their effect on the weight. In this case, we have to really to keep in mind that some of these patients are already frail, and so weight loss may not be desirable, while for other that are overweight, we may want some weight loss. However, we may want just fat loss, and we should really reinforce physical activity to maintain the muscle mass. And then side effect and cost. So second agent, the sulfonylurea here are very efficacious. They're very low cost. However, as side effect, I have a hypoglycemia. Definitely in the elderly population, the glipizide should be the most favorable to use. Thiazolidinedione should not be really used in this population, since they can give edema and trigger congestive heart failure, re-exacerbation, and therefore are not the best choice. DPP-4 actually fairly well tolerated, very low side effect. However, the cost is high, but it can be a very good choice for control of postprandial hyperglycemia if able to afford it. SGLT2, they're fairly new, they're fairly well tolerated, intermediate efficacy. They have a side effect, genital infection and dehydration that might actually not be the best side effect for this population. And then there are two injectable medications, GLP-1, that are very efficacious, especially for postprandial hyperglycemia. However, the cost is high. And insulin, that is very efficacious as well. However, the hypoglycemic risk is quite high. I want to point it out also that both the SGLT2 with the EMPA-REG outcome and the GLP-1 in the LEADER study have been shown to have decreased risk of a cardiovascular event rate and mortality. So these may be favorable in patients that have already macrovascular complication as a possible choice of medication. If we really need to go into an injectable medication, metformin should always cut on and can be added insulin or mealtime long-acting GLP-1. How about insulin? Insulin, as I said, is very effective for glucose management, and many of your patients may be already on multiple daily injection when we start to see them as an elderly population. They can be on basal and mealtime, or can be on mixed insulin. The problem with insulin is that it has a very high risk of hypoglycemia. So in this population, we want really to mitigate the possible risk of hypoglycemia and make the algorithm or the use of insulin the easiest possible. So we tend to use basal insulin for both basal bolus or mixed insulin. In the case of mixed insulin, we tend to use 70% of the total dose as basal insulin, and the basal insulin should be given in the morning. The basal insulin can also be titrated to achieve a goal of fasting glucose between 90 and 140 milligram deciliter. And so we ask the patient to check their finger stick every morning fasting. And ideally, if more than 50% over a week of the finger stick are above 140, we could increase the basal of 2 units. If, however, at least 2 of the finger stick are less than 80, over a week, we should decrease the basal insulin by 2 units. For the mealtime insulin, we should try to reduce the amount as much as possible. If the mealtime insulin is less than 10 units, then we can actually deceive fully the insulin and the pre-meal insulin and add no insulin agents, fast choice as well, again, metformin. If GFR is above 45 milligram deciliter. If less than 45, then we should consider other second-line agents. If the mealtime insulin is more than 10 units per day, per dose, then we should decrease by 50% the amount of insulin and then add non-insulin agents and try to scale it down the amount of insulin before meals. Because one of the things that, as I already mentioned, we try to mitigate, to avoid in this population is hypoglycemia. Hypoglycemia can, in this population with long duration of diabetes, can be not felt, hypoglycemia and awareness. However, also cognitive dysfunction that can develop during this time can interfere with identification and treatment of hypoglycemia. And also other comorbidity and treatment can actually mimic hypoglycemic symptoms. Subject may develop both hypoglycemia or fear of hypoglycemia that actually can determine no compliance with medication, falls and hospital visits, and also exacerbation of chronic condition. So these are data collected by Dr. Mushi on episode of hypoglycemia in subjects above 70 years old with type 2 diabetes and A1C above 8. And we can see that actually patients with hypoglycemia, they were 65%, independently of the A1C value. And we can see that 46% of the hypoglycemia was clinically significant with the blood glucose level less than 50. So it's very important to simplify as much as we can the insulin regimen. And we should always review with the subject in front of us and possibly with the caregiver, and if there is a family member, how subjects are doing. Are they forgetting their mealtime insulin? In this case, can we reduce the mealtime insulin? Can we avoid it and just use a long-acting oral medication? They're making error on the insulin scale. Can we avoid the insulin scale? If it's not really avoidable, maybe we want to build just a very simple sliding scale, like a 2-dose scale. So there is not much to remember for the subject. Are there hypoglycemic episodes, especially fasting in the morning? In this case, should we titrate down the long-acting insulin? And for the postprandial hyperglycemia, can we use a non-insulin agent? If it is needed also for administering insulin, a caregiver, we should coordinate with the caregiver the time that they're able to assist the subject with dosing, and sometimes also just dexterity can be a challenge.
Dr. Tochi, I'm sorry, we're running out of time. I should have given you a heads up earlier. I apologize.
I have a couple of more slides.
Okay, we only have 10 minutes left, and we still have Gina.
Okay. I'll try to go very quickly, just the last couple of slides.
Okay.
Okay, so I'll skip a few slides. And I want just to briefly just give a few words on long-term facilities that in this case, especially on the bottom of these slides, patients with long-term facility have a limited life expectancy. So A1C should be 8.5. Mostly is the fasting blood glucose that should be between 100 and 200 that we want to monitor, and we want to monitor according to how complex is the therapy. And the last thing that I want to say, that on these elderly population, we had also end-of-life problem. And in this case, we don't want to be aggressive. And the one thing that we want to avoid is hypoglycemia and hyperglycemia, meaning blood glucose above 200 that can increase dehydration, electrolytes, abnormalities, kidney failure. Otherwise, we want to be as conservative as possible. So as my prior colleague said, you know, we want really a partnership even more in this population with our caregiver and with the patient to try to best manage them and avoid both hypo and hyperglycemia. And so in this age group, simple is better, and the intensification of treatment can improve both hypo and hyperglycemia. Thank you.
Thank you, Dr. Tochi. And Gina, I apologize for the short amount of time that you have, and perhaps we can include some of your information in the next webinar as well. And then just for all the participants to know, we will not have time for question and answer today, but we're going to do all. Please do go ahead and type in your questions. We'll follow up with all of them via email. Are you there, Gina? We see your slides. Are you there online?
Okay, can you hear me now?
Yes, we can. Thank you.
Okay, perfect. Okay, good afternoon, everyone. With being mindful of time, I'm just going to skim through the highlights of my presentation to really give you some of the things that might be most helpful for you. So I'm really focusing on helping you in your state find resources and or partners that will help you address either those that you're treating with diabetes or aiming to prevent diabetes. Okay. You can read who we are. We're Health Promotion Council. We're an affiliate of Public Health Management Corporation. So we work closely with the National Nurse-Led Care Consortium here at PHMC. Our mission is really to prevent and manage chronic disease, and we do that through three main areas: direct services, whether we provide diabetes education programs or counseling or prevention programs. we build capacity of organizations throughout the state, as well as try to influence policy and systems change to help support all of the pieces that are needed to help people better manage their chronic illnesses. So many of the resources that I'm going to share with you come from the national level and filter down through the main government agencies like the Centers for Disease Control. And this funding will go to either the larger state departments like Health, Human Services, Aging, Rural Health, as well as they may go to major cities within your state, community-based organizations or non-governmental organizations and health systems. And then those same organizations could possibly be subcontract partners like we are with our State Department of Health. So the two main focus areas that this funding is addressing our large population with diabetes and prediabetes, and they're really focusing on increasing access through evidence-based programs, diabetes self-management programs, and diabetes prevention programs, and to reduce the barriers, especially around access to programs, awareness of the population and providers about these programs, and trying to overcome some of the reimbursement and coverage challenges that interfere with people accessing programs. So one of the main programs that's already been discussed is the National Diabetes Prevention Program. I will talk about how to access the program, as well as diabetes self-management education programs. So these two organizations, American Diabetes Association and the American Association of Diabetes Educators, offer, they are the two national bodies that certify these programs. The certification is required by the Centers for Medicaid and Medicare Services to be eligible for reimbursement through Medicare. So whether you're a location that is interested in offering these programs or you would like to refer out, this is just important that you know that the programs are evidence-based. They are certified to make sure that what you are receiving for your patients is quality programming. So some of the other resources that are available, I provided some links. There are organizations that are using the Self-Management Resource Center, which was formerly known as the Stanford University Suite of Programs. These can be used as curriculum for certified programs. And then the National Association of Chronic Disease Directors has an excellent resource list of other programs that are also evidence-based that can be used within the setting. The benefits I have listed on the right are that they are more, they're culturally adapted and can be used to train lay leaders to actually facilitate these programs. And again, it is evidence-based. So it's a lower overall cost of offering programs, and the more clinical staff, like the registered dietitians and registered nurses, can serve as an oversight of these lay leader groups and really provide a more robust programming to reach the many people who desperately need these programs. So how do you access the resources? I'll talk a little bit about the funding and how to connect with these partners so that you can collaborate. The CDC has three main sources of funding. There's the 1305, 1422 funding. These are actually taken right from the CDC website, and the main goal is to take a look at that overarching diabetes, heart disease, obesity, and the associated risk factors. And then how do we tie in the childhood obesity issue in trying to promote school health? 1422 can actually, as in our state, Philadelphia is our main city that offers this funding source to help promote the availability of diabetes prevention programs. And then the third source is really targeting American Indians and Alaska Natives, and this is the single largest funding to help support these organizations. So if you're in one of those states that serves this population, again, it's focusing on the risk factors associated with chronic disease, all related to diabetes and diabetes prevention, as well as the other risk factors. So I'm not going to go through details. This is, again, taken right from the CDC site. The goals are really to focus on environments, how can we better use clinical and other health services, and then how do we make those community clinical linkages? So each state implements these programs in a little bit of a different way, but all of the states have to address one or more of these objectives or goals. How do you find the resources? This is not a perfect site, but it is at least a start. You can go to the CDC and find out who is funded and whether or not you could potentially partner with them. So you have the slide, so you have the link on how to find diabetes prevention programs in your state. This is just a map on how to access what's actually on the website. These are taken, again, directly from the website. You can click on your state and you can find the multiple partners that are offering DPP programs, and they may be very willing to partner with you to bring these programs on site or work with you on how to best refer your patients to these programs. They're very open and interested in partnership. Same with diabetes self-management programs. Again, you can go to the AADE website and find programs. AADE lists both the ADA certified and AADE recognized programs. So this just is a map through the ADA site. And then to go through some of the other partners you may want to explore, your quality improvement organization. The quality improvement organization has contracts with the Centers for Medicare and Medicaid and is offering the Everyone with Diabetes Count. In Pennsylvania, we are partnering closely with them on our Administration for Community Living grant. So ACL, with partnership of the National Council on Aging, offers funding to implement evidence-based diabetes programs and chronic disease self-management programs. Again, I mentioned the National Association of Chronic Disease Directors. They are working in multiple states to bring more diabetes prevention to rural areas, as well as helping many states develop action plans for sustainability that addresses awareness, availability of programs, coverage of programs, and how to best help the referral process to these programs. And in summary, I just encourage everyone to assess your population's needs, and I don't want to exclude staff. You may have staff that might benefit from these programs and then serve as an overall role model for your patients. And then what's your ability to meet the needs of your patient population? Explore existing resources and partners that you might be able to leverage new or strengthen existing programs, either within your organization or within other organizations. Partner to attract the interest of payers. So the Medicaid and Medicare payers are very interested in addressing the needs of their members, and you share that in common. And then again, learn from other states, explore some of the sites that I've shared. There's lots of best practices and success stories, reach out and create new partnerships. Thank you.
Thank you so much, Gina. That was very helpful. And there's a ton of resources in your slides, which I want to let everyone know you will get copies of the slides and the resources that have been shared by all 4 of the presenters today. So thank you to everybody. Just real quickly, while you're, if you guys can see my my slides, we'll just go and remind you that the final webinar in our 4-part series is on February 22nd, and it's focusing on the clinical management and periodontal care for diabetic patients and individuals experiencing homelessness. Should be great. The social determinants of health academy is now open, and it is also focused on diabetes and looking at social determinants of health. So information about how to register for that will also be sent out to you. And I want to give a big thanks to everybody, and thank you for patience with some of our technical issues, as well as some of the time constraints. All of our contact information is here for all the organizations that have been presenting. And we look forward to seeing you at a future event. So thank you very much. Nicole, do you want